A very good evening and welcome to this 81st edition of Thursday Musings. Today we'll be discussing on a newer therapy and practically from the people who are doing it. Next slide, please. Let me hand over the session to Professor Dr. Tufan Pati sir. Sir is from Cuttack. He is the chairman of this program. Sir, over to you.
Thank you, Alim. Thank you, Alim, for handing over that meeting to me. Next slide, please. We have got with us one of our regular moderator, Dr. Amrit Patjoshi, who is with me from Odisha, Bhubaneswar, and Dr. Alim Siddiqui from Lucknow. Both are professor of psychiatry and strong young members of Indian Psychiatric Society. Now it is my privilege to introduce the chairperson. Next slide, please. Dr. Abdul Majid from Srinagar, my dear friend, currently working as professor of SKMS Medical College, Srinagar, Honorary General Secretary, Indian Psychiatric Society, North Zone, Honorary General Secretary of Indian Association of Geriatric Mental Health, Direct Council member of IPS, member World Psychiatric Association Addiction Psychiatry Section, International Fellowship American Psychiatric Association, many national and international papers including book chapters, presented research work in many national and international forums, has been collaborating research work with researchers of various prestigious institutions like Douglas and University of Canada, PGI Chandigarh, AIMS New Delhi, and NIMS Bangalore. Awards: National Award of Excellence in Mental Health, Glory of India Award, and Rashtriya Gaurav Award. Welcome, Dr. Majid.
Thank you very much, sir. Thank you.
Next slide, please. We have with us Dr. Dipanjali Medhi, Professor and HOD, Department of Psychiatry, Guwahati Medical College, Assam. So is a very well-known name in psychiatry, not only in Eastern India, but also all over India. Welcome, Dipanjali Madam. And with this, I hand over this meeting for further proceedings to the chairpersons.
Thank you very much, Dr. Tufan sir, Dr. Alim, Dr. Amrit, the live wires of the Thursday Musings. You have been carrying it all along, and I'm happy that I'm part of 81st. I was part of many of them, and in fact, the first one as well. So it has been a grand success, and why not once you have patron like Dr. Tufan Pati and once you have moderators like Alim and Amrit Bhai. So many congratulations to you, especially for carrying this activity and much needed one, as we are almost into the third year of COVID, and the physical contact and physical classes have been a rarity for last couple of years. I think this is a very, very innovation is there, but this is much needed as well for our residents, our faculty, our PG students, including me as well. So I think it has been very, very informative all the way through. All the programs I attended were excellent, and the faculty and the topics chosen. And today we are specifically discussing about treatment-resistant depression, and we understand that there are many pathways which have been strongly implicated in the pathogens of depression, and one among them is the glutamate-mediated neuroplasticity, which is thought to be the final common pathway of antidepressant action. And we know that glutamate acts on metabotropic receptors and inotropic receptors in the brain. The NMDA receptors play an important role in the neurobiology of major depressive disorders, and there are different glutamatergic targets that have been considered as a treatment for depression. And one of the very important molecules that has come of late into the arena is the ketamine. And we know that the onset is rapid of ketamine as it acts through the NMDA receptors. Mainly ketamine, if historically seen, although it will be deliberated more upon by the worthy speakers who will be taking us along the presentations, it would be used as an anesthetic in the battlefields, as a party drug or maybe in the operation rooms as well. So of late, we have seen, as I said, that it has been used in treatment-resistant depression, and the mechanism that has been postulated, that has been actually, the evidence has been found, is that there is an activation of synaptic plasticity by increasing BDN, of brain-derived neurotropic factor. its translation and secretion, and it also acts via glycogen synthase kinase 3 inhibition. So as I said, that it acts within a very, very short period of time. So we can actually prevent many, many suicidal attempters from losing their life. And it could be somehow, I would say, a game changer in the treatment of depression, particularly treatment-resistant depression. With these few words at the start, I would request Dr. Deepanjali to introduce our worthy speaker. They are well known. They don't need actually introduction, particularly Dr. Nilesh Shah and Dr. Tushar, but they are the veterans, or I would say the experts in their own field, but would be very, I think, after the end of the session, would be all very well aware what's going on in the field of ketamine therapy as far as treatment-resistant depression is concerned. Over to Deepanjali for introduction of the worthy speakers.
Ma'am, you have to unmute yourself. Chintan, roll the slides forward.
Okay. Thanks, Dr. Mazid. Am I audible now?
Yes, ma'am.
Okay. So, respected Dr. Organizing Chairman of today's 81st Thursday Musing Program, Dr. Tufan Poti, and the moderators of the program, Dr. Amit Patrojoshi, I think I'm right, and Dr. M. Alim Siddiq, and then speakers, Dr. Nilesa and Dr. Sushar Surendra Bhatt, Chairperson Dr. Abdul Mazid, the participants, and my fellow secretaries. And so the topic of today's discussion, the ketamine therapy in refractory depression, discussion with case vignettes, is a very important topic chosen for today's program. And I definitely hope that the speakers definitely is going to do justice to the topic very nicely. And both of them are highly acclaimed speakers, especially Dr. Nilesa from Mumbai. So I am very much happy to introduce him to the house. So Dr. Nilesa, who is currently is a professor and head Department of Psychiatry, Lokmanya Tilak Medical College and Sion General Hospital, Mumbai. His areas of interest: pharmacotherapy, electroconvulsive therapy, consultation liaison psychotherapy, dementia, and his major achievements. He has more than 30 years of experience in the field of field as a clinician and as a teacher. He has more than 90 publications in various national and international journals, and he presented papers at more than 150 conferences, seminars, and symposiums. So, I welcome Dr. Nilesa to the program. And our second speaker is Dr. Tushar Surendra Bhatt. The slides, please. He's the assistant professor in SCPM Medical College and currently in consultant in Chaitanya Hospital, Dhule. And he did his MBBS, is a gold medalist, and DPM from LTMMC, Sion Hospital, Mumbai. He was awarded with fellowship of International Society of Bipolar Mood Disorder. He is a fellow Beck Institute of CBT, Philadelphia. He has 7 index journal publications, and he is CFMG and USA certified. Currently, already I have said, currently he's working as an assistant professor in SCPM Medical College and consultant at Chaitanya Hospital, Dhule. So I welcome Dr. Tushar Bhatt to today's program, and I request Dr. Nilesa kindly to start his deliberation. Dr. Shah, please.
Good evening, and I'm very happy to be over here, and thanks to all the organizing committee members for inviting me and giving me this opportunity along with my colleague Dr. Tushar to present on our experience of using ketamine for now last more than 5 years. I'll try and share my slides. Can you see my slide?
Yes,
Yeah.
yes.
Okay. So as it is seen, ketamine, and it was called as Buddy's drug and Special K. And the advantage is that this vial, which contains 10 ml, is available for just 100 rupees. So rupees 10 per ml. So it's a very, very affordable treatment, unlike many other antidepressant medications. So today we are going to discuss where do we use ketamine, how do we use ketamine, when do we use ketamine, in which patients we can use ketamine. And so I will start with two cases which were published in our own Indian Journal of Psychiatry in 2013. So we have been using this ketamine for now more than about 10 years. And this is a very interesting case which kind of initiated and gave us confidence to use ketamine. This 23 years old male patient with OCD for 5 years on fluoxetine 40 milligram and bupropion, he attempted suicide by slashing his throat. His bupropion was hiked to 450 milligram and fluoxetine to 60 milligram. Now, usually in this kind of patients, ECT is indicated, but ECT was not considered in view of his ensuing exams. So, in an emergency situation, to control his suicidal ideations, the authors, Harihar C. and Daseri P. and Srinivas, gave injection ketamine 0.5 milligram per kg body weight intramuscularly. He tolerated it very well. There were no side effects. And after about 2 hours, his HDRS score dropped from 21 to 4. So very rapidly acting drugs, within 2 hours, the rapid decline in score. 3 days later, he received a similar dose and his HDRS score dropped from 10 to 7 within 2 hours. During the subsequent weeks, the improvement was maintained and suicidal thoughts never returned. He appeared in his examination and did well to his satisfaction. So this was the one case which was very interesting and that motivated us to use ketamine in more and more patients, particularly this kind of students, which we all work in medical college, and this kind of students come suddenly, and if they have a suicidal ideations, emergency, one option is ECT, but it will cause little cognitive disturbances. Instead of that, ketamine is easy to use and very effective. Same authors also presented a second case, a 21-year-old male suffering from recurrent depressive episodes since 5 years, reported recent worsening of his symptoms along with suicidal ideations. He was on bupropion 450 milligram and fluoxetine 20 milligram. It seems these people were very fond of combination of fluoxetine with bupropion, SSRI versus NDRI. So all neurotransmitters are covered. And as he was not willing for ECT, he was taken up for ketamine. 0.5 milligram per kg of IM ketamine was given. After 2 hours, his HDRS score dropped from 21 to 6. He did not have any side effects. After 3 days, he was given a second dose of ketamine. After 2 hours, his HDRS dropped from 13 to 6. And he reported little nausea, which subsided with oral domperidone. So one of the use of ketamine is in acute emergency situation where you are pressed and you cannot use ECT for particularly suicidal patients or suicidal students, then one can consider use of ketamine. Are we using ketamine? And can we really use ketamine for the treatment of depression? Yes, very emphatic yes. At Sion Hospital where I work, at least every day, 1 or 2 patients, we use ketamine. And over a period of time, we have learned that oral ketamine is as effective as intramuscular ketamine and as effective as intravenous ketamine. So nowadays, we hardly give intravenous or intramuscular ketamine to anyone. What we do, we take 2 ml of ketamine, put it in a 300 ml of water or juice, and ask the patient to drink this juice gradually over a period of 45 minutes. We monitor his pulse and blood pressure at the baseline after 15 minutes, after 30 minutes, and after 45 minutes. Majority of them tolerate very well. Once in a while, if they develop little nausea, then we give domperidone. Otherwise, majority of them tolerate it very well. Like ECT, we give first and second week 3 times a week. So Monday, Wednesday, Friday, Monday, Wednesday, Friday. Subsequent 2 weeks, we reduce to the frequency to twice a week. So Monday, Thursday, Monday, Thursday. And last 2 weeks, we give Monday and Monday. So totally over a period of 6 weeks, we give 12 ketamine orally, ketamine therapy orally. Let us see what the international literature has to say on this. So ketamine is an FDA approved anesthetic agent. It is used in human as well as veterinary medicine. As it was mentioned by the chairperson that it is an NDMA glutamate receptor antagonist classified as Schedule 3 non-narcotic controlled substance. At higher doses, it is sometimes abused as a street drug called Spatial K. It was used for sedation for children and adults. And ketamine, perhaps the most widely used agent in the world. Ketamine does not depress the respiratory systems as do regular anesthetics. Therefore, the patient is at less risk. The major advantage of ketamine is that all other anesthetic agents may cause respiratory depression, while ketamine is one of the agents which does not cause respiratory depression. Additionally, once administration of the drug is stopped, its effects are very short-lived. So if the person is drinking or if you are giving intravenous ketamine and if the patient develops little confusion or dissociative state, you stop the intravenous or you ask the patient to drink it slowly or stop drinking, immediately the effects wear off and the person is again absolutely fine. So some psychiatrists are already using ketamine injection for selected patients. As I mentioned, we were also initially using ketamine injection, but now we are using oral ketamine in majority of the patients. Doctors can do this legally because ketamine is an FDA-approved anesthetic drug, and the rapid short-term benefits in suicidal patients might outweigh the risks associated with its use. So let us see some case reports which are very, very useful. This was published in 2000, 21 years back. 7 subjects with major depression completed 2 test days that involved intravenous ketamine, 0.5 milligram per kg body weight or a saline solution under randomized double-blind condition. And what they found was that subjects with depression evidenced significant improvement in depressive symptoms within 72 hours after ketamine, but not placebo infusion. And the conclusion was the results suggest a potential role for NMDA receptor modulating drug in the treatment of depression. So the evidence for use of ketamine was right from 2000, almost 20 years back. There were other 2 cases which were published in 2006. One patient had 18-month history of depression, unsuccessfully treated with citalopram, mirtazapine, venlafaxine, and ECT. So real treatment-resistant depression. She was given 5-day course of ketamine intravenously, and this is little lower dose. Usually we use 0.5 milligram per kg. Here it was 0.27 milligram per kg per hour. her BDI improvement from 36 to 11 in 4 days, and she remained well 12 months later on citalopram 40 milligrams per day. So in a treatment-resistant depression for 18 months, just a consecutive ketamine injection for a period of 5 days, and she was cured. Not only she was cured, but that cure was maintained for 12 months after this, only on citalopram 40 milligram. The second patient had 16-year history of depression, unsuccessfully treated with fluoxetine, nefazodone, mirtazapine, venlafaxine, amisulpride, lithium, and ECT. They have used all possible antidepressant drugs available in their country. And he was given 5-day course, continuous every day of ketamine, again lower dose, 0.3 milligram per kg per hour. And again, you see severe depression, BDI from 52, it dropped to 9 in 4 days. He relapsed after 2.5 months and 8.5 months and had 2 further 5-day infusions, which were successful. At 12 months, he remained well on lithium 500 milligrams per day. So we have very good evidence to suggest that it is rapidly acting drug. It is useful in treatment-resistant depression, and also it can be used in emergency situations where the person is not willing for ECT or ECT cannot be used. Here is a randomized trial, a randomized placebo-controlled double-blind crossover study of 18 months, 18 patients with treatment-resistant major depression given a single intravenous infusion of ketamine 0.5 milligram per kg over 40 minutes. This is the standard method which most of us use. 71% met response criteria the day following ketamine infusion as compared to 0% subjects treated with placebo. I have not seen this kind of result with any antidepressant drug. Similarly, in treatment-resistant major depression, a 55-year-old male subjects with a treatment-resistant major depression and co-occurring alcohol and benzodiazepine dependence received an intravenous infusion of ketamine over 50 minutes. Over the previous 5 years, the subject had been treated with all possible antidepressants, as you can see on the slide, and he showed remarkable improvement. So even in depression associated with comorbid substance use, ketamine may be useful. Augmentation therapy had comprised of methylphenidate, valproic acid, lithium, everything they had used. And throughout 2002, the subject had received cognitive behavior therapy. All of these were tolerated well, but failed to achieve remission. After ketamine infusion, his BDI score improved from 26 to 9 in 2 days. So here, depression with comorbid substance use also showed a treatment-resistant depression. Remarkable. This sounds like a magic. And to experience this magic, you have to use ketamine to see that actually it occurs in our day-to-day clinical practice. They have this serial infusion of low-dose ketamine for major depression. 10 depressed patients were treated with twice weekly ketamine, infusion of ketamine 0.5 milligram per kg administered over 100 minutes until either remission was achieved or 4 infusions were given. Side effects were assessed with the Young Mania Rating Scale and Brief Psychiatric Rating Scale. Patients were followed naturalistically at weekly intervals for 4 weeks after completion of the infusion. 5 of 10 patients achieved remission status. There was no significant increase in YMRS score, so no induction of mania. 2 of the remitting patients sustained their improvement throughout the 4-week follow-up period. Ketamine infusions at a lower rate than previously reported have demonstrated similar efficacy and excellent tolerability and may be more practically available for routine clinical practice. Further research to test relapse prevention strategies with continuation ketamine infusion is indicated. Okay. So finally, when I am saying so much about the ketamine, the question arises that what is the safety and tolerability of ketamine? Is it safe? Yes. Clinically, ketamine is popular agent for emergency department procedural sedation in children with ample evidence to support its safety and efficacy. It is widely used as an anesthetic agent in children and in veterinary practice. Although its psychotomimetic side effects have led to its misuse and abuse, there is no evidence that ketamine causes physical dependence in humans. In fact, we have been using for 5 years and I have yet to see any patient getting addicted to ketamine. In addition, recent studies found no evidence that repeated, albeit that's a limited evidence, typically less than 4 exposures to ketamine increases the risk of more severe or more protracted psychosis, perpetual changes resembling dissociation, severe emotional distress, or euphoria in healthy subjects or in patients' population. So since when we were using intravenous ketamine, some patients used to develop little dissociation, little confusion, and then we will stop the infusion for a while. Now, since we are using oral ketamine, the person is drinking ketamine, and if he feels a little drowsy or he feels a little uncomfortable, we ask him to stop drinking. And after 5 minutes, when he's a little better, then he can resume drinking at a slower pace. Here again, about tolerability and side effect profile, 450 subjects received at least 1 dose of active ketamine. In 833 subjects, active ketamine and 621 placebo infusions were administered. Out of this, only 10 adverse mental status events were documented in 9 patients. So only 2% patients, subjects that were deemed related to ketamine administration. All but 1 adverse reaction resolved by the end of the test session. So it shows that ketamine administration is very, very safe, very, very effective, useful in treatment-resistant depression, useful in emergency situation, and very, very affordable. Just imagine that you can get 1 ml ketamine for 10 rupees and you put it in the juice, or if you are not fond of juice, put it in the water, drink, and you will be much better. So thank you very much. And now I will hand over to Dr. Tushar for further proceedings for his presentation.
Dr. Tushar, please unmute.
Okay. My presentation is visible?
Yes.
Okay. Thank you, Dr. Nilesh Shah, sir. I would like to correct his one sentence. I'm not his colleague. I'm his student rather. He was my PG guide, and I would like to remain his student forever. The life. I would like to thank Live CME group. The thing started over there in once some chatting session was going on, and then just started brainstorming happen in a Live CME WhatsApp group, and then this program resulted in this. Okay, what we see in a study trial, let's start with something, why we need something new here. If we see the study results, sequential treatment alternative review, only 30% met the criteria for remission during citalopram treatment. And unfortunately, 70% of your patients are not improving. That is the big thing regarding treatment resistant depression. There are lots of different definitions regarding treatment resistant depression as a non-response to 2 adequate course of pharmacotherapy in patients with depression. So we are in need of something definitely bigger, which will do something magic for us. So then for psychosis, we have clozapine. But what about depression? Then we found this treatment very useful. But why we need one more thing, one more antidepressant? So we have SSRI, we have SNRI, lots of different combinations we have, but they took lots of time to work, and usually 2 weeks. The fastest acting antidepressant is, do you know which one? I know most of us know the answer. It is not sertraline, it is not escitalopram, it is not desvenlafaxine, rather mirtazapine. But again, study shows mirtazapine takes 8 to 10 days to start the action. So till we have to work uh, fast in such kind of patient. This is one aspect, and another aspect is treatment of resistant depression. So we have lots of options like thyroid, lithium, atypical antipsychotic like olanzapine or aripiprazole. So we are in desperate need of something which will act as a firefighter in a depression patient. So we have some NMDA blocker already in our armamentarium like topiramate, lamotrigine, memantine. So answer is all of above we have. But I'm desperate in search of something which is faster and more efficient. So let's welcome our new friend. No, it is not your foe, Mr. Ketamine. It is child. I know the things are we don't have that much of data. It is uh, for symptom wise or as an indication, not US FDA approved, but drug is US FDA approved for lots of other indications, IV approved. It is developed by Park Davis, today a part of Pfizer, this pharma in 1962. It is classified as Dr. Shastra has mentioned, NMDA receptor antagonist, and also bind opioid mu receptors. It might increase glutamate in prefrontal cortex by activating glutamate neuron, disinhibiting presynaptic glutamate, and blocking NMDA GABA interneuron. So if we see, the excess activation of NMDA is implicated in depression, schizophrenia, Alzheimer, addiction, and chronic pain. If we see the US, chronic pain ketamine clinic is already on verge. There are lots of ketamine clinics you can see in USA, and now they have added depression as one more indication. We'll come to that point again. So where exactly ketamine acts? It acts on non-selective ionotropic glutamate receptor. So it works like non-selective to cations like sodium, calcium, and potassium. Ligand operated glutamate and glycine. It is blocked by magnesium. We'll see one nice video by Dr. Stephen Stahl here.
Agents, as well as brain stimulation techniques, such as electroconvulsive therapy, are both capable of correcting dysfunctional neuroplasticity and increasing neurogenesis. Monoaminergic antidepressants likely exert their therapeutic effects by influencing downstream signaling, such as increased alpha-amino 3-hydroxy 5-methyl 4-isoxazole propionic acid or AMPA receptor expression, decreased N-methyl-D aspartate or NMDA receptor expression, and decreased glutamate. Suggesting agents with direct activity at these downstream targets may lead to faster treatment response. Antidepressant treatments may modify the AMPA to NMDA receptor ratio, resulting in downregulated NMDA receptors and increased AMPA receptors. The modification of the AMPA to NMDA receptor agents.
Okay, this is a very different and good what we say animated video of how exactly this works. So it proposed to blockade of NMDA receptors interneuron, as I just mentioned, and it works on AMPA receptors. In turn, AMPA receptor signaling leads to activation of mTOR. mTOR is mammalian target of rapamycin pathway and rapid induction of dendritic spine. The rapid antidepressant effect of ketamine may be related to these indirect effects of AMPA receptor signaling. So I just, sir has mentioned, we have also same patient. We started these things in 2012, and we are using in resistant depression where multiple combinations has been tried, where lots of combination we use like escitalopram, nortriptyline, augmentation, but still we when we couldn't succeed, we use this ketamine. Thankfully, uh, there is no ketamine infusion works very nicely in this kind of patient. These are few case reports I presented. One more strange study we found on internet is lamotrigenized brain. If you find patient bipolar depression, if you really would like to prevent mania, yes, mania has been reported, but very few case reports, hardly 4 or 5 case reports we could find on PubMed. But still, if you'd like to prevent, one study suggests use lamotrigine before use of ketamine. When we suspect anything like patient might land up in psychosis or might land up in mania after giving ketamine, or atypical depression symptoms are there, then we can use lamotrigine in such kind of patient. And now let's see real battle. So as sir has suggested, we can use oral solution. If we see the vial of ketamine, or we see it's 50 milligram per ml. You can use, we have injections also. It's available in two strengths, 50 milligram and 100 milligram per ml. It can be administered orally, injection, IV, IM, rectally, or even nasally. Recently, one enantiomer of ketamine, S-ketamine, is under consideration for approval under US FDA for this indication. What we need is just simply 100 cc NS 1 ml syringe. Now, if we calculate the dose 0.5 milligram per kilogram over 45 minutes, if we would like to give this dose, then simple calculation, the solution is 50 milligram per ml and dose is 0.5 milligram per kilogram. This is for IV, and same is for oral solution also. The simple calculation is count the weight of the patient. If patient is 70 kg, you will need 0.7 cc of ketamine solution. So as sir was telling, 1 ml will cost you 10 rupees. I will reduce that cost to 7 rupees, not even 10 rupees. And weight if is 80 kg, you will require just 0.8 cc of ketamine for this thing. There, pardon, point, if you want to give intramuscular, there is one study published in IJP, Indian Journal of Psychiatry, 0.25 milligram intramuscular within 2 hours of treatment, depression score dropped by 60% in 3 groups. This article is published in our IJP. Now, where there are some precautions where we should avoid this treatment. If patient has condition in which increase in blood pressure, if patient is already hypertensive, and if patient has some problems in heart rhythm, some arrhythmia, kindly use the ketamine cautiously. If patient has schizophrenia or another psychotic disorder, use ketamine cautiously. Theoretically, this can precipitate psychosis, but thankfully, we have not seen a single patient yet which has landed in psychosis after using ketamine. A patient has condition in which an increased intraocular pressure like glaucoma, it use would be hazardous, and if there is any proven allergy, then also we should take precautions for that. So this is the simple setup what we require. These are ketamine drug available in the market. This is simple 100 cc syringe what we do at in our setup. This is IV cannula and 1 cc syringe to calculate the dose. This is the simple setup we require. And if you want to really monitor the patient, then multi-parameter is always available. Put chest leads, because in private hospital, if you're giving ketamine and if you're charging something from him, then you have to monitor him properly. And even if it is a government setup, no issue about that. ECG should be monitored. if we see this is not a graph or something. These are the ketamine clinics available in USA. This is the graph of that thing. So it is not very rare thing. It is very rampant nowadays. And so where is the problem then? The problem is if patient has psychotic symptom, then what to do? I tried to find lots of answers, but many says avoid ketamine in this of patient. How many doses you will require? Most of the studies, double blind, placebo controlled, and most of the case reports, actually case reports are more, they shows 6 to 8 doses are efficient to relapse. And most patient, we acts as a firefighting drug because our SSRI, mirtazapine, all of this drug will take at least 14 days to act. But till then what? As sir has just mentioned in one case, patient was unfit for ECT. And at that time, how to handle that patient for 14 days? Then this is a life-saving drug. This will reduce the suicidal thoughts of the patient. And many studies has found ketamine reduces the suicidal thoughts in hours. I'm not talking in days, it's in hours. Long term side effect we have not seen till now. I'm also using under guidance of Shah sir since 2012, but long term side effect we yet to find. Oral sublingual formulation, and now recently intranasal, that is a S-ketamine. That may be some one of my pharmaceutical friend told me that to get license for ketamine for depression, pharma might not find money, so they are developing intranasal ketamine so that they can market it. Spravato, I think one brand available in US, intranasal ketamine. Ketamine is no more heroic or risky treatment than say ECT, clozapine, or that matter large section of pharmacopoeia. This is I took this sentence from Dr. Chittaranjan Anurade sir. He is very he's expert in using ketamine. So special thanks to Dr. again Chittaranjan Andrade sir. In JCP, Journal of Clinical Psychiatry, you will find series of articles about all these things in ketamine. Dr. Nilesh Shah sir is my mentor. Dr. Maskar, okay, I would like to special mention. He's my physician who works with me, and he monitors my each and every patient. That I took that precaution because physician is in my campus. That might has given me good confidence to use ketamine. And special thanks to Dr. Stephen Stahl giving me permission for use of his article and video for this presentation. So defeat depression and bring back smile to your patient face. This is a very good firefighting drug, I will say. A new realm of improvement in patient, and we have one good new drug in our armamentarium. Thank you very much, organizers, Live CME Group, Dr. Nilesh Shah sir, Dr. Siddiqui sir for excellent arrangement and allowing me to present in this program. Thank you.
Thank you so much, sir. It was an enlightening presentation, both of you, sir.
Thank you.
Over to chairpersons for their opening remarks.
Okay. Thank you.
Sir, can you stop the slide?
Yeah, I'll do that.
Yes. So first, my thanks goes to Dr. Nilesh Shah for his very enlightening presentation today on the topic. And after hearing his presentation, definitely a lot of our colleagues will will leave their apprehension to use the ketamine in their clinical practice, and more patients of treatment-resistant depression can be cured nicely, and especially the suicidality of the this can be reduced. I hope so. And thanks Dr. Tushar also, and for his very enlightening presentation today on the topic. And we are very helpful. We are very much enlightened by his presentation about the how the molecule works, especially the neurobiological basis of the ketamine as an NMDA receptor antagonist. And ultimate, though it is antagonist, but ultimately there is glutaminergic function is increased, and by that the other neuroplastic changes happen in the brain. And so for me, I just request my students to have more to study the subject more in length and breadth, on especially this ketamine, which is so easily available, so cheap, and then definitely can be a good choice in treating the treatment-resistant depression, which are we know that from the different epidemiological studies that 10 to 30% of patients with depression remains as treatment resistant. So we definitely had earlier a lot of other adjuvant or augmentation strategies like switchover techniques or combination treatment or some adjuvant treatment. So we had, but this ketamine can be definitely a good choice, especially because of its very rapid effect. The efficacy is so rapid, and for that probably we can have some our armamentarium of treatment of this treatment avenues for treatment-resistant depression definitely will go broader and broader. So thanks to both of you, the speakers, and I request Dr. Majid kindly to say a few words.
Yeah, thank you, Dipanjali. It has been a wonderful lecture by both, I would say, a very, very experienced Dr. Nilesh Shah sir and dear friend Dr. Tushar. I think they have had a lucid presentation with almost everything explained, but I had many questions in my mind, but once I saw the chat box and there are a lot of questions which are propped up, and I thought that they're almost the same. So I would say that if the way the ketamine is seen to be so effective with the cost effectiveness, I don't think any other antidepressant has as of now. That's why probably pharma is not projecting it as a wonderful molecule, a magical pill. So you never know, down the line after 6 months, 1 year, 2 year, you may have a tablet of ketamine that has to be taken every 2 days for first week, and then as Nilesa said, the next 2 weeks you have to take it twice a week. Then finally, the last 2 weeks, in the fifth, sixth week, you may have to take it once a week only. So you never know. The time is not far away, probably, that you may have ketamine tablets as well. So I think it's over to Dr. Aleem before. I think it would be ideal for me to hand it over to Aleem and Amrit so that the questions are taken, and if there are any queries or if there is any clarification which is sought, may be addressed by the learned speakers. Over to Dr. Aleem and Amrit.
Thank you, sir. Sir, I start with a very basic question in the chat box. Is it ethical to give ketamine in a depressed patient? The presenters, please. Nilesh sir, you're muted. Please unmute.
Yeah, I don't see any problem of ethics. It's a medicine, it is available, it has been used for so many years, and if it is going to save somebody's life and reduces depression, I don't see any problem with ethics.
Okay, thank you, sir. Then, sir, there was a question that it is FDA approved for. Is it currently FDA approved for depression or for anesthetic?
As an anesthetic agent.
Okay, so if we start using it in a different indication, so how do we set this thing right?
Yeah, we are using many medicines which are not FDA approved for that particular indication. So it is off-label use of that medicine. And S-ketamine, which is a nasal S-ketamine, which is available now in USA, is FDA approved.
Okay, thank you. Before I proceed, I think Dr. Mohandas sir is there. Sir, your comment, please. Then we can proceed further.
No, Nilesh has already told. US FDA has approved only.
Sir, your comment on ketamine in general.
No, ketamine in general, yeah. Ketamine, I think there was mention of, especially initial case studies, then Zarate's article that has revolutionized. At that time, there were two groups. who were telling that it is useful. Some people say it was not useful. But currently say ketamine is effective, especially for a anti-suicidal effect of ketamine. But approval is only esketamine, as Nilesh has told. Whether we can give orally with the consent for an anesthesia and using for some other indication, I am doubtful. Legally, I am doubtful. Even the mechanism also Tushar Bhatt talked about, and in between initially by Nilesh. Basically, the AMPA activation, AMPA activation, which will induce the mTOR signaling, it will affect the dendritic spine excitability. If you want to go to a recent article that has come in Friends in Neurosciences, 2020 late, that is dendritic spine excitability might be one of the mechanism of ketamine action. Second action is, it is the type of bursting in the lateral habenula that is blocked by ketamine. I will not go into details because I have presented it 2.5 years back in Vancouver for a meeting. Whether it is useful for bipolar depression, there are articles on bipolar depression. Will it produce a switch? There are case reports, but the exact percentage, nobody knows it. But will it be useful for bipolar 2 depression? My answer will be bipolar 2 depression will be the most resistant. Usually there is an indication if things are really not working, possibly if that condition. Secondly, will it produce addiction? As Nilesh has told, ketamine and esketamine, addiction potential, when it is used for a therapy, it is used for depression. The recent article I am quoting in 2021, no addictive potential as Nilesh has told. Will it produce psychosis? Small minority, it may, but depending upon the type of dosage and duration and vulnerability. I cannot answer the percentage because the patients varies. Will it replace almost like a clozapine? Tushar Bhatt has told, answer is no. Answer is no. Any Dick and Harry cannot write it. And here, clozapine can be started. Can you start, if it is for treatment, so why don't you start ketamine initially instead of any antidepressant? Answer so far, no, we will not. There's no indication. Will you give ECT initially? Answer yes, in a developing country, provided there is a suicidal ideation. In India, a rapid effect and a shorter hospital stay from JSTQ onwards. The people have talked it, Nilesh knows all these things, and Chitu also has talked about it. Fine. Do I use ketamine? Initially, I tried, I think almost from the beginning, when it was early 2010. I was trying 2010 or 2000, before 2010, 2009 or 10, when I was in Elite Mission Hospital, in theater, operationally with the help of an anesthetist, in a treatment-resistant cases, I didn't get much improvement in 3 of my patients. But doesn't mean that all patients will respond. There may, because the biology of depression is different, patient characteristics are different. So there are a select group of people who will respond faster. Which are these people? He has already told mTOR signaling. Do they have a genetic basis or biomarker for that? We are yet to have it. There are some studies which really make it. We do not know for sure. Europe, many people use it. Rasmussen, somebody has referred, I don't know, Tushar or Nilesh has put off Rasmussen study, though it's not new. Now, in bipolar depression, if you want to read it, recent articles in 2020 and 21, reviews have come on the switch to affective disorders, etc. Complete literature, case reports, the reviews have come. Frontiers in Psychiatry 2020 or 21. I think it is worthwhile to read it and critically comment. So, from my side, answer bottom line, it is a wonderful therapeutic addition to our armamentarium. It is very good, especially for a suicidal patient, provided you are doing in good hands. Drops, yes, ketamine nasal drops, we don't have it. So will you work in our place? Up to you. Whether the consent is needed, it depends. If you meet with some problem, you are in a soup, because we do not have an indication for those type of things, at least in India. We can talk about theoretically, but practically, I will not do it. I will not do it. Others can do it. It's up to you. I don't want to take any, what do you call, this type of, I mean, whatever is evidence, I go with that. I had discussion with these people, Siegfried Kasper, Zarate, then others. I had discussion, I had debates also on it. So it's a good drug. It is already US FDA approved, ketamine, nasal drops. Even ketamine and ketamine, people say that effectivity is there, addiction potential is low, provided you give in the right time. Let us wait and watch, but in the given patient, those people who are experienced like Nilesh or Chitu or Tushar, if they are confident, please refer to them and let them do the task. Not Mohandas. I will go only with the evidence, and I don't want to. Can you give combination with mood stabilizers? Answer is yes. Answer is yes. Plenty of articles are there. Lithium, you can use it, because lithium also has got glutamatergic effect that you know pretty well. And all antidepressants are NMDA antagonists. The only difference is the people are confused with what is NMDA and non-NMDA receptors. That is the biggest problem. Whether it's a big problem, people are not aware about the subclassification. And Tushar has talked about something on M2, M3. Sorry, Tushar, the recent evidence says that only when you diagnose these people very early, there is an effect, otherwise no, because the people will come to you very late. That is only theoretical. Metabotropic to make receptor, it's all questionable. Okay, thank you very much. I have taken so much time. Alim, sorry for that.
Yes,
That was an excellent presentation.
thank you, sir. Thank you. Coming to the chat box question.
Just a minute.
Yeah.
The physician associated with Dr. Bhatt, Dr. Tushar, he was raising hands.
Yeah, I
but
tried to unmute him. If he is there, he can again raise his hand. I tried to unmute him.
I think his opinion is important because associated of Dr. Bhatt.
Dr.
I think he's.
I think he was. I just saw him.
He had raised hands.
Yeah.
Is he there? If he's there, we request him to again raise hand. We will like to listen to him. His experiences along with you. And Arim, you can go with the other questions.
Okay, go with other questions.
Yeah, sir, what are the other rapidly acting antidepressants other than ketamine? Any idea?
Mirtazapine is fastest acting, what we know till now.
Okay.
The another thing which is likely to come in next few years is psilocybin, magic mushroom. And already there are some case reports where only 2 doses at an interval of 7 days and depression is cured, a treatment-resistant depression is cured, and person improves for 7-8 months.
So
So
I
there are
think
case
session
reports.
on psychedelics
That
sometimes.
is that, and that is a hallucinogen.
Yes.
Yeah,
Risk of precipitating psychotic illness, it is concurrent or hidden.
Dr. Mohandas wants to say something.
My dear Tushar, Mutrasapin, even if you give 30 to 45 milligram, it has got only modest antidepressant efficacy. Okay. Rapid acting antidepressants, umpteen articles have come. Those who are, we had a session in WPA session with the CANP president. Many people might be knowing. I was talking on newer antipsychotics or drug antipsychotics in pipeline. He was talking on antidepressants in pipeline, and plenty of rapid acting antidepressants are there. We will discuss it when there is a seminar or symposium on it. I don't want to take any time from that. I think I would have given a lecture on it now, but which I don't want to. Thank you.
Yes, sir, we can have it in the future.
That is depending upon the time, right?
Yes, sir. Sir, there is a question, rather a good question. It can be used in depression. Does it affect the cognitive dysfunction? So it is acting on the cognition or only on the depression part?
Mainly on depression part, mainly on suicidal ideations. I've seen many questions, and the one of majority want to know how exactly it is used. We are using an outpatient department. Patients come in, patient needs, patient is severely depressed, or there is a resistant depression or severely suicidal. We ask the patient, we give prescription in triplicate. The most available brand is Amiket, A-M-E-K-E-T, Amiket. That's a brand from Neon Pharmaceutical. Across our hospital, pharma company, medical store, it is available. They bring one vial of 10 ml. We take 2 ml from that vial, put it in 300 ml of juice, which we request the patient to bring, and then ask the patient to drink it gradually over a period of 45 minutes, sitting in outpatient department. We do it once, we do it twice, we do it 3 times, where we monitor his pulse and blood pressure at the baseline after 15 minutes, after 30 minutes, after 45 minutes. And we see that he is comfortable, there are no side effects, he's feeling better. We request him to do it at home. So then patient and relatives do the same thing at their home. They did not even come to the hospital. The same thing, they can do it at their home. Very simple procedure, very easy procedure, very effective procedure.
So doing that at home, then again the addiction thing, does it, are you concerned? Or?
See, we are treating patients for last more than 5 years, and we have hardly see any patient who is addicted to it. Okay. The longest duration for which we have given is 3 months every day. This was one of the resident doctor, and he was not able to attend his rounds and his duty because of severe depression with suicidal ideation. We started ketamine, and he started showing improvement. He was resistant to even ECT and lots of antidepressant. With ketamine oral therapy, he started improving gradually over a period of time. He started attending rounds. He started attending his outpatient department, other rounds, and he continued every day ketamine for a period of 3 months. He is remarkably improved. He is going for his round. Now he has started gradually reducing. So instead of every day, he is taking thrice a week, and he plans to gradually reduce and stop ketamine over a period of next 2-3 months.
Nilesh, your ethics committee has approved it?
We take permission from the doctor himself that, see, this is off-label treatment, and this is not an experiment. We are not doing any experiment, and we have not taken any permission from ethics committee.
It is not it is basically when it is not approved by the FDA or even Indian thing, drug controller for a specific indication, suppose you give it, you can argue it is the autonomy of the patient and you are thinking of benefit or harm principle, you can argue, but unless until you get an approval from the higher authorities, yes, these type of cases you can do it. Why don't you apply for that or even recommend the beneficial effects? Then everyone can really try, provided there's approval from the government, right? Till the
Yes.
time, I think you should try quoting your examples and let them do it. Otherwise, it is going to be a problem as far as I'm concerned. Especially in Kerala, it's a consumerist activism is there, right? Even our own colleagues will be suing against you, right? That is the problem. So better you try to motivate the higher authorities through the societies, if needed, advocacy group, and if there's approval, wonderful. Many people can, you can outline the guidelines, whatever is possible from your experience. Okay, Tushar and Nilesh or Chitra Chitu, if you get an approval, it is easy for everyone to follow. Otherwise, very difficult. You might be doing a wonderful job, but unfortunately, legally, very difficult. Permissibility is questionable.
Sir, good suggestion, and we will look into this. One more question, which was saying that whether it can be used as a first-line treatment. Clozapine was used as a fourth-line treatment. Then it became third line. Dr. Kshitij Kapoor recommends that it should be second line because after first failure of antidepressant, if you use any other antipsychotic drugs, the success rate is 15%. While if you use clozapine, the success rate is 50%. And now I was recently told that in Bangladesh, clozapine is used as a first-line treatment for schizophrenia. So there are psychiatrists who have been using clozapine as a first-line treatment. And now everybody is using clozapine. We all have a very good experience with clozapine, and we are getting very wonderful results with clozapine. So over a period of time, as we get more and more experience, why not? And I think that it may come up, as Dr. Mohandas suggested, that once all of us put up some application to the authorities and request them to allow the actual permissible use, not the off-label use, but the actual use of ketamine in depression, I think we can use it as a first-line treatment also. Why unnecessarily give antidepressant with lots of side effects over a period of time when you have a medicine which will rapidly act and patients will recover within days. So that is going to come over a period of next...
Nilesh, your idea is very good, but it can be a second line clozapine because as Kshitij has told that, Kapoor, even Stephen Starls, 8 years back, his article, if it is very good, why don't we start earlier? Earlier means within 2 years of treatment. That is on the onset of the illness. But to recommend as a first line, nobody is going to approve, but still we can try it. Ketamine, sorry, you cannot equate. Sorry, I am guarded. Okay, but your wish is welcome. Idea is good, but leg is mine. Thank you.
Yes, sir. And just one more question on this aspect. Is there any specific consent that we need to take? And do we need to have anesthetist collaboration? Dr. Tushar Bhatt has a physician with him. So how to go about this aspect?
Okay. So when we were giving intravenous ketamine, we were doing exactly like ECT, that we used to take full consent in writing, take signature from the patient relatives, and one anesthetist was there when we were giving intravenous ketamine, and we were monitoring all the parameters like we do it during ECT. Over a period of time, we have realized that oral ketamine is as effective as intravenous ketamine. So why unnecessarily take a risk and patient has to go through? Now patient is actively suicidal and you want to give ECT. First of all, you have to take the anesthesia fitness. Anesthesia fitness, they will say do the blood investigation, X-ray, ECG. It will take 2-3 days in the municipal corporation hospital. We have to admit the patient and then take him up for ECT. Rather than that, he can sit in the OPD, he can drink ketamine, or you admit him, no need to admit. Oral OPD basis, patient can take ketamine. And if we get more experience, probably you can request a family physician that patient cannot come to the hospital, he can go to his family physician. Family physician can monitor his pulse and blood pressure and allow him to take ketamine under his guidance.
Okay, so I think the questions are piling up in the chat box. We need to quickly cover this. Question from the chat box. It can cause rise of BP and tachycardia. So any role of atropine?
As I said, we are giving it orally, we monitoring it. If you see increase in blood pressure, stop drinking ketamine. Within 5 minutes, the blood pressure will come down.
Okay, what is the preparation of oral ketamine?
Amicat, A-M-E-K-E-T, Amicat injection, Neon Pharma, which we are using. So it's the same intravenous IV, same thing. The same IV preparation we are using orally.
Okay, the magic is short-lived. So how is it to be combined with other medications, or you want, sometimes it can be given independently also?
So whatever antidepressants are helping the patient for partial improvement. Suppose you have started, patient is on ABC, escitalopram, venlafaxine, mirtazapine, and he is somewhat improved. Same antidepressants which are effective can be continued throughout the ketamine therapy. And once the patient improves, the same medicines can be further continued after the ketamine therapy.
Okay, sir, anything about the ketamine assisted psychotherapy or ketamine assisted interview? Any latest?
We are not doing anything like that.
Okay.
Same for me.
There
Okay.
are literature on it. Ketamine induced ECT, ketamine induced therapy. Fine. Thank you.
Any sir, your comment on the cystitis, ketamine causing cystitis?
Yes.
So
there are rare, absolutely rare side effects are there. Yes, there are reports of ketamine-induced cystitis, but it is extremely rare.
okay, what is the evidence that what is the duration of remission after the ketamine treatment? Any studies, any experience?
Clinical, as I presented, some patients improve for 6 to 8 months. So even with a short course of ketamine,
without any other antidepressant?
No, they have to be maintained on antidepressants. Majority of the cases, they have not stopped antidepressants altogether, but the antidepressants are continued for maintenance therapy.
Okay, and how to procure ketamine? You can just write an order and buy it.
Yeah, we give prescription in triplicates and we send it, give it to the patient. Patient goes to the medical store and buys it, and then he brings it to us.
Any problem with this?
Slight different system where to pay by check payment, and I have to keep record of which patient I'm giving how much ketamine. I have to return the empty vial back to the chemist. This is system in our area. The FDA drug inspector asked return vial of used ketamine. That was news, I think I found.
The same thing that you get the cartridge here.
Yeah.
Gun cartridges here. Okay. So regarding seizure threshold, it could lower it. Any issues you have found?
No.
And your comment from the literature?
No, we have not come across any reports where it reduces the seizure threshold and patient gets a seizure. There are rare reports of cystitis and increased raised intracranial pressure, but not routinely. There can be increase in blood pressure. There can be little dissociation, drowsiness, little nausea, vomiting. Yes, these are common thing, but not seizure.
There is a question on intranasal dose of ketamine.
We are not actually using intranasal. We do not have experience, but some people are using is 0.01 milligram in both the nostrils. They have to this. The as ketamine, of course, abroad they are using intranasally. And I know one doctor, Vishwa Mohan, in Ahmedabad, who is putting the ketamine in this canister and giving intranasally. But I find orally is much easier. Why unnecessarily give intranasally?
Okay. What is the maximum duration of ketamine therapy and how to prevent abuse and overdose?
Usually we give it for 6 weeks. We have given it in one patient for continuously for a period of 3 months. And so far, none of our patients have developed addiction to ketamine. In fact, after sometimes they gradually reduce and stop.
Okay. It should be given under supervision all the time, or?
We do it initially 2-3 times under supervision orally. And we monitor pulse and blood pressure, these two things at the baseline after 15 minutes, after 30 minutes, and after 45 minutes. And in 2-3 sessions, if there is no change, patient is confident, relatives are comfortable, we allow them to continue it at home. And we just say that with pulse oximeter, they can measure the pulse and BP instrument is available. So at the before and after, they can monitor the BP.
Okay. Sir, what is the use in old age patients?
Yes, you can safely use it in old people also.
Okay. Any risk of spasm, and what is the percentage of switch to mania?
Hardly any. We have not seen any patient so far switching into mania.
Okay.
But
Sir,
there might be some case reports where there is a ketamine related psychosis or switching to mania. But we have not seen. It's not a routine thing.
I could find
Any-
only 5 to 6 case reports total
Yes.
on PubMed, not more than that.
Okay. Okay, sir. Sir, there is a question that how to place it, how to store it at our place. Any special precautions for storing it?
We do not store it in our hospital. We ask the patient to bring it from the chemist shop. We are not supposed to keep it with us. Doctors are not supposed to keep it with them.
Okay, sir. Any literature on its use in schizophrenia in the patients who have negative symptoms or catatonia?
Not so far.
It will land up in, it's a dissociation inducing drug.
One interesting case I can share. We had one boy who was had presented with little psychotic symptoms, and we were not very sure what we are dealing with. And pediatricians recommended MRI scan. Now for MRI scan, patient was very disturbed and not cooperative. So the anesthetist gave ketamine to sedate him so that MRI can be performed. And after that, he developed severe catatonia, which gave us the clue that it is NMDA receptor encephalitis. And then we did the NMDA receptor antibodies and it was positive. So NMDA encephalitis, limbic encephalitis, or NMDA receptor limbic encephalitis recruits more and more NMDA receptors which are destroyed, which are causing the encephalitis and the symptoms of encephalitis. And ketamine can aggravate that thing. So one has to be a little careful, and ketamine can induce catatonia. So refrain from using it in this kind of situation.
Okay. Would it be defensible in a court of law in a case if there is disabling side effects? Professional indemnity would not admit liability in such a case.
Okay, so what we do, we tell the patients that you have treatment-resistant depression and this is available with your consent. If you give the consent, if you give the permission, we are willing to try it. And since we are trying it orally almost for 5 years, luckily so far, we have not faced any complications or major problems.
Okay. Then the questions are just repeating. How long? Yeah. What has been your success rate?
As good as ECT.
Okay. Then there are two regarding. Okay, there are two regarding use of methylphenidate and use of modafinil. Any experience in that? Those drugs. This is not the topic, but if you want to cover it.
Modafinil is my favorite drug, and I use it very, very frequently in patients of depression as an add-on therapy and to prevent the daytime sedation. And methylphenidate per se, I'm using very widely in patients of ADHD. So we get a large number of patients because we have LD clinic, and many patients with LD has concomitant ADHD. So usually we use methylphenidate, again, very, very effective medicine, very useful medicine in children for treatment of ADHD. In adults with treatment-resistant depression, yes, it can be used. Elderly patients with treatment-resistant depression, it can be used, but not very that effective.
Okay. Question from Dr. Usman. He's from Pakistan. Is there a risk of being taken up by quacks and used without following the mentioned guidelines? There is
Quacks can use any medicine for that matter. Why only ketamine? Any antidepressant. We know many of the doctors, not only the family physicians, but neurologists, gastroenterologists. In fact, one of my close friend, he says, Nilesh, 50% of my patients, gastroenterologists, to come to me have anxiety, depression, and I prescribe escitalopram, and all of them improve. Now, he is not a quack, but he is regularly using. He says, I don't refer the patient to psychiatrist. I treat myself.
okay. After how much rise of BP and pulse, we have to stop the oral ketamine?
So beyond expectable limits, so 5 or something like that, it's fine. But if the blood pressure increases more than 140 systolic and more than 90 diastolic, stop.
Okay. See, what happens usually, heart rate increases because patient is getting some visual hallucination during that ketamine period, during infusion period. So slight increase in heart rate is expected from these patients.
Okay. What about the dissociation symptoms in the seen during the treatment? Have you seen any, sir?
Yeah. Once in a month, I do come across with dissociative symptoms, and they usually self-limited up to 1 hour. Beyond that, till now, in last 5 years, I came across only 2 patients whose dissociation lasted more than 2 hours. At that time, I gave him Serenus Finargan, haloperidol, and patient improved in half an hour. And these are only 2 patients I came across. Shah sir can elaborate.
Orally, you hardly get any hallucinations or dissociative symptoms. Suppose the person feels a little drowsy or says, I'm feeling a little uneasy, you ask him to stop drinking. Intravenously, we do the same thing. We use this micro drip set where we adjust the micro drip to 100 drops per minute. If necessary, we increase to 110, 120. And if the patient says that I'm feeling some noises or seeing something, we reduce it to 80 drops per minute. So reduce or stop infusion for 5-10 minutes and then restart with the lower frequency.
Okay. Suppose the medication is left in the vial. So do you throw this medication or reuse it?
It's a bulb, no? So you can take it out and can remain in the refrigerator.
Okay. What are the baseline investigations that should be done and monitored?
For oral ketamine, we do not do any baseline investigation. For intravenous, yes, all the investigations which you require for anesthesia fitness, blood investigations, X-ray and cardiogram.
Okay. There is a question on use of ketamine in postpartum depression, lactating women, effect on fetus, query.
Okay, so far we have not used, but I think it's safe. Even if there is a treatment-resistant postpartum depression, there is no reason why we cannot use it.
Okay, can IV midazolam be given as a pre-medication before ketamine to prevent dissociation and confusion?
I would suggest it is not necessary. If the patient is developing confusion or this hallucinations or dissociation, stop the infusion. That is easy way out. You don't have to continue infusion. Or reduce the flow of the ketamine from 100 drops per minute to 80 or 70 drops per minute.
Okay, and any evidence regarding this intramuscular route? What is the usage?
I was surprised that in Indian Journal of Psychiatry, 2 case reports where intramuscular ketamine was given. But before we were giving IV, and now oral is so easy. Why unnecessarily give intramuscular?
Okay. Then there is a question regarding use ketamine to reduce BPD symptoms. I think it is borderline personality, you want to say?
Per se borderline personality disorder, do not if you don't have to. We don't treat borderline personality disorder. We refer it to our senior doctors or doctors whom we do not like.
Okay. Okay. There is a question. I think this is a repeat question. How much dose of ketamine in juice and any preference of the juice?
We ask the patient whether they would like to take it in the water, because water it is little bitter, but many people say pani mein hi lenge. And juice, whatever patient likes, we say aapko jo bhi juice acha lagta hai, cranberry juice, orange juice, mango juice, whichever you bring it. Only thing, preferably bring 300 ml. Sometimes patient bring 250 ml. That's fine. So whatever juice patient prefers, we mix it in that and request the patient to drink the juice.
Okay. Is there any transdermal patch under preparation?
Not to my knowledge.
Okay. And can it be used in teenagers and adolescents?
Yes, we have used it in teenagers, children. Today only, 14 years old, treatment-resistant girl with multiple suicidal attempts. We are giving ketamine and she is tolerating it well, and she is also responding well.
Okay. Comment is there, was it withdrawn a few years back as post-anesthesia suicide was reported?
See, suicide can happen with any anesthetic agent. Why ketamine? There are better agents to commit suicide rather than ketamine.
Okay. What to do for nausea with oral ketamine?
You can get Ondem 4 milligram twice a day, or Domstal or any antiemetic drug you can give along with it.
Thank you, sir. I think we have covered all the questions and at 9:29 only. So we are just in time.
Yeah, just last question. Can I answer? Oral dose and IV dose?
Yes, sir.
IV is 0.5 milligram per kg body weight. And as Tushar said it, it's very easy. You divide the weight by 100 in ml. So if the patient is 70 kg, 70 divided by 100, 0.7 ml. So simple. It has to be given in 100 ml of saline over a period of 40 minutes or 45 minutes. Orally, the dose is 100 milligram, 150 milligram, 200 milligrams orally. So we usually start with 100 milligram, that is 2 ml. And if the patient shows partial response, and if we need to increase the dose, we go to 3 ml. And maximum, there are reports, and Dr. Andrade has shared that he gives up to 4 ml, that is 200 ml orally, 200 milligram orally.
And does tolerance develop on repeated use?
Not to my knowledge. Patients do continue to respond.
Okay. Okay. Sir, so have we covered? I think there, yeah, Nilesh sir Zindabad is also a comment. So from our side, and Dr. Tushar Zindabad.
Thank you. They have not called us Dr. Ketamines.
I have one last question after the last question. What are the drug-drug interactions in case of ketamine?
Hardly any drug-drug interactions, because all other antipsychotics or antidepressants particularly are continued and patient takes ketamine. So
the patient are likely to have comorbidities, because many of our patients have many comorbidities.
Yes, yes. So whatever medicines they are taking for hypertension, diabetes, ischemic heart disease, whatever medicines they are taking must be continued.
Okay.
Usually patients do not evaluate further intraocular pressure, usually, unless they have severe symptoms. Is it not necessary to have a routine evaluation of the IOP?
In fact, one of our students did this thesis on rate changes in intraocular pressure with psychotropic medications, and many of our patients are on multiple psychotropic medications. And in 100 consecutive patients, not a single patient we found that there was increase in intraocular pressure. So I fully agree that there is a possibility and one has to be cautious, but it's not a routine thing. Once in a while, if there is a patient complains of pain in the eyes or redness of eyes, yes, you have to immediately refer him to an ophthalmologist and do whatever is recommended by him.
Okay. Yeah. So, sir, Tufan sir, please carry on.
Oh, yes. But there is, I think there is always the danger of the blind lady with his eyes blindfolded. And our patients are becoming increasingly litigant. So should we not develop a thorough guideline for this,
I think there was, sir, Tufan sir, there was a suggestion that can IPS recommend it?
No, but as long as it is not legal, we cannot recommend, but there is nothing comes in the way of developing. We can develop it. And we can force, as IPS can force upon the drug controller that it should be accepted, because that is so, it is a big arsenal in treating depression. Why we should not use it? IPS can be instrumental, must be instrumental. You are now the IPS office bearer, and all of us are there. We must try that from a professional front, it should be approved for treatment of depression in the prescribed doses.
Sure, sir.
And but developing guidelines you can develop. That is separate entity. If you will develop it, subject to fact that the approval will be done. Till that period, this off-label use, as my dear friend Nilesh is doing since long, it appears inspiring.
So, sir, if I summarize, as per experience of both of you, it is a very good induction therapy for depression. You have not encountered many sinister side effects. It has been fairly well tolerated, good response, early response, and along with that, you continue the other antidepressants so that the patient continues in remission. So it is a good add-on for induction, for acute phase, early, so that this time is saved. I think that would be the summary.
Yes.
Thank you so much, sir. And final comments from the chairpersons.
Thank you, Dr. Aleem, Dr. Nilesh, the speaker, and Dr. Tushar, Dr. Amrit, and Dr. Tufan as well for having a wonderful session today. I think Aleem has perfectly nicely concluded it. That is an initial phase that we can have for treatment-resistant depression, ketamine as a therapy, but long-term probably we have to rely on other antidepressants. But as of now, as the literature suggested, the both speakers talked about, ketamine seems to be a very, very promising molecule for treatment-resistant depression, particularly once you have suicidal patient. So to save the precious lives, I think ketamine can be tried in many, many of our patients who are not responding to conventional antidepressants that we are using in our day-to-day practice. Thank you very much for inviting me, I would say, and thank you the speakers for making us much, much wiser, giving us a lot of knowledge about this ketamine, and the participants who asked the questions which were very, very relevant. Dr. E. Mohan Das sir, who I think benefited, we always benefit from in whichever session we are in. And it's over to Dipanjali for any last comments before we hand it over to moderators and Dr. Tufan sir.
Thank you, Dr. Mojib. And so I would like to thank the organizers, Dr. Tufan Poti, Dr. Siddiq, Dr. Pattu Joshi, and for inviting me to share this session. And so I really very much got enlightened by listening to Dr. Nilesa, so who so nicely presented his session. At the same time, he so widely he cleared our doubts in the minds of our participants today. So that definitely will help all the clinicians to use ketamine in our clinical practice. And so my thanks to Dr. Tushar also for his very elaborate presentation and contribution on the topic. And so finally, I request the moderators to wind up the session.
Thank you so much, chairpersons. Sir, Amrit has to leave for a
yes, I know.
emergency tragedy. Yeah, sir, you have to take over.
So I am taking over his duty of proposing a vote of thanks. First of all, I sincerely thank Nilesh, my old dear friend.
My pleasure.
For immediately accepting to come in this lecture. And he is quite well known to using ketamine, everybody knows it. And I have heard from many of his students, not only Dr. Tushar, but many of his students who have interacted with me, that he is a very much inspiring teacher, very good teacher. And in his deliberation today's evidence, he has inspired more than 300 people today. If legal sanction comes, I think all the 300 people will immediately start ketamine clinics. Thank you, Nilesh. Thank you very much. And Dr. Tushar, your presentation has been very nice. Thank you very much. I missed the comments from your associate. Maybe he left because he had kept on raising hands. I marked it. But by the time I asked him, he was not there. Your presentation has been very nice. I will request both of you to make a proposal so that IPS takes it up. We'll fight with DGCA to get it approved. I do believe that we are using many more dangerous medicines in many disciplines. It does not appear to be dangerous at all. Why we should not use it? And I sincerely thank in this meeting Dr. Alim Siddiqui. Dr. Amrit had an emergency of one of his friends. He left the meeting. He informed both of us. And he asked me to proxy for him in moderation. But it was not needed. Dr. Alim Siddiqui singularly was quite efficient. He covered all the questions. Saying one by one, all the chats he covered in a very small time, very well. Thank you, Alim Siddiqui. That is why you are so. And Dr. Abdul Mazid, he just 10 days ago recovered from COVID. Now today is smart and active. Thank you, Dr. Mazid. And Dr. Dipanjali Medi.
Yes, sir.
Within a minute of my request, immediately accepted. Yes, I shall be there. Thank you very much for being with us and enlightening with your invaluable inputs. I thank all the participants for keeping and sponsoring this event, which will continue in future also. And with this note, I thank everyone on behalf of Indian Psychiatric Society Old Sister Friends, whom I am representing as a member also and as the chairman of this program. Thanks everybody. Good
Thank
night.
you very much.
Have a good
Good
dinner. Good sleep.
Thank you so much, Tufan sir. Thanks to you for allowing us. Sir, we can.
Bhavesh, how are you?
Yeah.
Bhavesh? You can unmute and say hello.
I am unable to unmute. Yes.
Hello,
sir.
Hello. Hello.
Yes. It was a very wonderful session. Very informative, sir.
Initially, I saw two Bhavesh on the screen.
Yeah. It was so
Oh.
because my internet connection was unstable in one device.
I thought you joined with another device to see the chats.